dealing with these Ehlers-Danlos patients is really a multidisciplinary paradigm. And most of my patients get sent to me by people like Claire Francomano and Alan Posinki. And they're usually asking me desperately, saying, please do surgery on this person. And I'm in the enviable position of saying, well, not yet, or maybe I'm not sure if they really fit the indications for surgery. So I don't know if I have just very well-informed internists or whether they're particularly aggressive, but I see patients from all over the United States, every one of the 50 states. And so these patients reflect not just patients in my local area, but really from Europe, South America, and every one of the states. So when I see someone who comes to me with severe headaches and neck pain, I'm thinking about craniovertebral instability, Chiari malformation, Atlantoaxial instability, vertebral instability, tethered cord syndrome, which can cause headaches, temporomandibular joint syndrome, occipital neuralgia, jugular venous occlusion, intracranial thrombosis and sinus thrombosis, which we're diagnosing much more commonly, hypercoagulability, Hughes syndrome, migrainous TIAs, pseudotumor cerebri, vitamin deficiencies, and now, to complicate things even more, some of these neuroimmunologic diseases like Hashimoto's encephalitis and anti-NMDA antibodies and Lyme's disease, and recently I've diagnosed 2 cases in the last 6 months of neurobichettes. But today I'm going to talk about how deformative stress of the brainstem and spinal cord underlies many of the observed neurological conditions that we see, and how correcting this deformative stress can substantially improve their lives. With this caveat that stress may underlie many of the symptoms, but with EDS there's always 2 or 3 or more factors playing. And so we may correct one aspect, but there's still several other components of the disease, of other disease processes that are affecting our clinical outcome. So I'm going to discuss these things. And when someone comes to me with this panoply of symptoms, headache, double vision, memory loss, speech difficulties, dizziness, vertigo, hearing loss, tinnitus, difficulty swallowing, choking, clumsiness, tripping, sleep apnea, numbness, paresthesias, weakness, tremors, unsteady gait, urinary and GI issues, I know either they're lying, and that's none of my patients, or the problem must come from the craniocervical junction. Or thirdly, maybe they have several things going on. It turns out that the cervicomedullary syndrome, that grouping of symptoms, occurs commonly with Chiari. And here's a Chiari with the cerebellum, the flocculonodular lobe of the cerebellum pushing down through the foramen magnum. And so the standard treatment of that is a decompression. The only problem is that 40 to 50% of decompressions ultimately don't improve the patient. These patients come back, once the stiffness wears off, they'll come back 6 to 12 months later and speak to the neurosurgeon saying, you know, I really have a return of most of those symptoms. And the surgeon will say, well, I did a technically perfect surgery. There's nothing more I can do for you. But the reason is that they have, Grab, Mapstone, and Oakes said that 50% of their pediatric group had ventral brainstem flattening. And Cahan said 40% of his cases of Chiari had basilar invagination. And Menezes talks about angulation of the odontoid process, and Millerat reported 96 of his 365 patients having a retroflexed odontoid. And this is a fulcrum over which the lower brainstem and upper spinal cord is pulled, causing symptoms from the brainstem and spinal cord. So this problem of complex Chiari and brainstem deformity was discussed by Doug Brockmeyer from his series from Mayo, and I've reported on it, and Robert Bolo. But Brockmeyer, in his retrospective study, said the complex Chiari was often due to brainstem herniation, medullary kinking, a retroflexed odontoid, abnormal clivoaxial angle, and basilar invagination. These were all conditions that commonly occur with Ehlers-Danlos syndrome. And it's because of the craniocervical instability that's the direct result of the ligamentous laxity. And so in order to treat this deformative stress from the anatomical deformity, at the Mayo Clinic, they had performed transoral odontodectomies on 20% of those complex patients, and on 56% of them, they had performed posterior craniocervical fusions. So the idea of performing craniocervical fusions on patients with craniocervical laxity is very common. We've been doing it for 40 years. And Gold recently published a study on 108 patients with atlantoaxial instability, and many of them have this retroflex pannus, odontoid, and the pannus, which is a result of chronic instability. So EDS is characterized by loose ligaments, and loose ligaments cause a floppy head syndrome. The head slides forward and backward over the spine, and this causes stretching and deformation of the lower brainstem, the upper spinal cord, the lower cranial nerves, the vertebral artery, and even the soft tissues, the ligaments and muscles. Even during normal motion, large axial strains are produced. Now, this is a cadaveric preparation by Professor Brieg. Here's a brainstem with the bone removed. And you can see with the brainstem in a neutral position, the glossopharyngeal nerve is relaxed, and then on flexion, it becomes stretched. And axial strains are produced. Here, these striped cardboard pieces are pulled apart as the brainstem stretches. That's the normal condition. And deformative stress is not only stretching, but it's also deformation or compression, and such as from a retroflexed odontoid or disc. And that compression not only causes local histological changes, but also increases the linear longitudinal tensile stress. So what's the pathological substrate of this stress? They are these small silver staining axon bulbs, retraction bulbs. The same things we see with diffuse head injury following a motor vehicle accident. We see them in the brainstem of shaken baby syndrome, and we were the first to describe them in the spinal cord and lower brainstem as a result of what we deemed to be stretch myelopathy, stretch encephalopathy. Now, I was told when I began the study 20 years ago under Professor Alan Crockett at the National Hospital for Neurology and Neurosurgery in London, that in these 10 patients who had died of compression on the brainstem, that I would find vascular changes. And these patients died because they didn't get enough blood flow to the brainstem. We found no vascular changes. We only found these stretch-induced changes. And in the subsequent 10 years, Pavlashok came out with his seminal work on what happens to stretch neurons, the microfilaments, or the neurofilaments and microtubules, which are responsible for conduction of metabolites up and down nerves, begin to clump. And several days later, they form these big axon bulbs, and uncorrected, those nerves will then separate in a process called axontomesis. And if you stretch a nerve experimentally, you see this clumping occurring very quickly, within 2 hours. And Setman showed if you stretch a mouse optic nerve just 20% of its length, you'll see the formation of these axon bulbs. And at 10 days, you see programmed cell death and death of many of these neurons. Wolf showed that if you stretch a neuron, there is distortion of the sodium channels, a big influx of sodium into the nerve, and this causes depolarization of the voltage-gated calcium channels and a reversal of the sodium-calcium gradient and a big influx of calcium into the neuron, which is shown here in yellow. Now, that process was inhibited by treating these nerves with tetrodotoxin, which blocks the sodium channels, shown down below. And calcium in the cell, in the neuron, can cause many deleterious changes. Arendine showed that if you stretch a nerve, you actually influence the genes in the nerve, the DNA, to begin production of certain biochemical products. In this case, N-methyl-D-aspartate that we heard of earlier. And the N-methyl-D-aspartate makes nerves more sensitive, but also makes them more vulnerable to other forms of injury. And stretching can cause programmed cell death or apoptosis. So then mechanical forces modulate gene expression and biochemical composition, directly affecting neurons and making them more sensitive and more vulnerable to injury. And we see electrophysiologically, just stretching a nerve, applying a slow stretch, we'll see a progressively increasing stretch, we'll see a decrement in the compound action potential. That's the nerve response to a stimulus. And if we apply that stretch rapidly, we see a much greater response, as in a whiplash injury. And we published in 1994 the effects of deformation on the brainstem in causing sleep apnea and how the sleep apnea resolved after a transoral odontodectomy and posterior fusion. And all of these concepts were put together in 2005. Actually, I went through 10 revisions on this, but we published an extended article on the concept of stretch-associated myelopathy, and I think it's entering into a general understanding. So now I'm going to talk about published indices of deformative stress, how we can measure instability radiographically. So the clivoaxial angle is fairly subtle, but incredibly important. And Scoville said that if the brainstem, or that angulation of the brainstem causes neurological instability. And 30 years ago, Gilder and Smoker said that an angulation of the clivus vertebral angle of less than 150 degrees was associated with bulbar symptoms, lower brainstem symptoms. And Menezes said that a retroflexed odontoid serves as a fulcrum over which the spinal cord is stretched and causes symptoms. So that clivoaxial angle looked very normal to me, and any radiologist would say that was normal. But if you measure that angle, it's abnormal. It's 130 degrees. Here's a normal clivoaxial angle. It's 165 degrees in the neutral, and here it is in flexion at 155 degrees, and on extension, 175 degrees, reflecting 20 degrees of flexion extension, range of motion between flexion and extension. That's normal. Now, the clivoaxial angle, therefore, is a surrogate measurement of basal invagination and of cervicomedullary deformity. Kim Riekate and Klopfenstein and Sontag published an article in 2004 wherein they found that all of their patients who underwent a Chiari decompression, who had a clivoaxial angle of less than 135 degrees, failed. When they brought them back and they performed a reduction fusion stabilization, 9 out of 10 of those patients had a complete resolution of their Chiari symptoms. Kubota showed also that Chiari decompression failed to improve syringomyelia if the clivoaxial angle was less than 135 degrees. Now, it doesn't take much to see that if you bend the brainstem over a kyphotic clivoaxial angle, you cause stretching of the brainstem. So here's a fairly normal clivoaxial angle. Here's a very kyphotic clivoaxial angle, and there's stretching of the brainstem and upper spinal cord. And the importance of this has been registered by many authors. This is not a new concept. It's well published. Ventral brainstem compression has also been measured by the method of Grab, Mapstone, and Oakes, published in 1999, in this series of pediatric patients. And they said if you draw a line from the basion, that's right here, to the base of C2, and then draw a perpendicular to that, that perpendicular measurement should be less than 9 millimeters. More than 9 millimeters represents ventral brainstem compression. And in those children with more than 9 millimeters, they performed a transoral odontodectomy going through the mouth to remove that ventral compression. And then they performed a posterior fusion. Now, other indices of instability include the palatovertebral angle. So the angle between the hard palate and the top of C1 should be less than 13 degrees. And Holy and Brewer looked at 600 normal cervical spine x-rays. And they said that the distance from the basion to the dens should be fairly constant, usually around 5 to 6 millimeters, but that more than 10 millimeters would be abnormal. So this distance from the basion to the top of the dens should be less than 10 millimeters. Now Lee's X-lines, simply the line from the basion to the middle of the lamina, that line should not be transgressed by the odontoid, or that would reflect basal invagination. The Harris measurement was based on his analysis of 400 normal subjects, and he said that the distance from the basion to the odontoid should be less than 12 millimeters, and importantly, the distance from the basion to the posterior axial line should be less than 12 millimeters. A distance of greater than 12 implied craniovertebral instability. So this line is excellent for measuring the presence of instability between flexion and extension. Now, there should be no translation, there should be no slippage between the skull and the spine on flexion extension. The skull should be simply tilting forward and tilting back over a central pivot point. And Fielding said that flexion extension is the only motion at the normal occipito-atlantal joint. Burns said there is no horizontal translation in the occipito-atlantal joint. And Wiesel and Rothman said the normal range of horizontal translation and flexion extension is no more than 1 millimeter. Movement of greater than 1 millimeter is clinically significant, and treatment by posterior craniocervical fusion is proved successful. And Punjabi and White said that more than 1 millimeter of translation and flexion extension is an important and useful criterion, and symptoms of weakness of the limbs and occipital pain are additional indications of instability. So here's a normal patient, or a normal bending. Actually, that clavoaxial angle is abnormal, but there's no sliding. You see that basion lies right over the middle of the odontoid in both flexion and extension. And here's an abnormal case where in flexion the basion has moved anteriorly, and in extension it's moved posteriorly. And there's 5 millimeters of movement, and the same in this case. Anyway, 3 years ago we published a series of patients who had deformative stress associated with an abnormal clavoaxial angle. This group of patients were children. And the primary outcome measurements were careful neurologic exams, sensory motor scales, the Asia scale, pain with a visual analog scale, quality of life index, Karnofsky index. We made up this brainstem disability index, a list of all the cervicomedullary symptoms, and then MRI measurements. This is the brainstem disability index. This is symptoms of the cervicomedullary syndrome. And our indications for surgery were the same as Dickman and Douglas Sontag of 1990, only we more specifically required headache and neck pain, and brainstem and spinal cord symptoms, and reproducible neurological deficits, and radiological demonstration of ventral brainstem compression and basilar invagination. And the surgery, the way I do it is I place the patient in a neck brace, position them prone in Mayfield pins, then I take the neck brace off, a small shaving over the back of the head, and prep. Here's a small Chiari malformation with some compression there. This is a suboccipital decompression. I usually remove about 15 millimeters of bone and do a very wide foramen magnum decompression. This is actually a cadaver here, not a real patient. We carefully drill holes for the screws, avoiding the vertebral artery, perform a reduction. And this is very important. I trained in London to do a lot of transoral odontodectomies. And now I've found that I haven't done one in the last 8 years because I'm able, after opening the back of the head and removing the muscles, to reposition the skull on the spine and normalize the relationship of the cranium to the spine, so that a transoral odontodectomy is only rarely required. As I said, I haven't done one in years. So this is the method by Kim, Riekate, Klopfenstein, and Sontag of traction, and then extension, and then I add a little translation to get the position perfectly normalized. And we look at the clivoaxial angle, the basio-odontoid measurement, the occipital-cervical angle, and the range of motion of the neck is actually surprisingly reasonably preserved, because we're only fusing down to C2, and the patients are usually hypermobile at the other levels. In this first series we published, surprisingly, many of them had autism or high-functioning autism. Outcomes were good. One patient had continued headaches. I'll show you a couple of cases. This child had repeated cardiorespiratory arrests, postural orthostatic tachycardia, decreased memory, vision, auditory changes, dysphagia, dizziness, gait change, weakness, sensory loss, fairly significant neurologic deficits. They went to many neurosurgeons, and for some reason, I don't know why they didn't see this immediately and recognize it. But the family were told to take the child home and prepare him to die. So we performed a routine surgery. Here's the fusion. And a year later, the child was playing sports, achieving A levels. Some years later, got a pilot's license, now studying aerospace engineering at a top university on a scholarship. This 16-year-old girl, severe headaches, 50% truancy because of headaches, and very clumsy, poor balance. She said, I know what to do, I just can't tell my body what to do. Jerking motions of her legs in class. Her teachers did not like her. They thought she was always disruptive. Weakness, hyperextensible joints, spastic reflexes, sleep apnea. MRI read as normal. And she had an abnormal clivoaxial angle. We fixed that. And there's the post-operative. Her pain went to 0. All her brainstem disability symptoms resolved. Her Karnofsky scale went to 100. Quality of life better than normal. Cycling 11 miles a day. The looseness in her joints just went away completely. And she went from being very floppy to very strong. Captain of the debating team, straight A's after college. So if we look at the whole series, we saw improvements in the ASIA, that's sensory motor findings, Karnofsky, and quality of life. And despite the small number of patients, we saw statistical significance of improvement in every case. Now, I want to look at some more recent data, and this is strictly patients diagnosed by Claire and Brad Tinkle with Ehlers-Danlos syndrome. And there were patients that we collected from July of 2011 to February 2012. So just a consecutive series of 20 patients. And this is a slightly preliminary thing. We only had the data from 18 patients, and now we've got it from all 20, but we haven't analyzed it yet. But I think we'll have 100% data collection on these patients. And so it's still in the process right now. So we asked them, in looking back, all of these patients had a craniocervical reduction, fusion, stabilization for being floppy-headed with a cervicomedullary syndrome. Most of them were pretty desperate. Looking back, I would still choose to have the craniovertebral fusion surgery. And 2/3 strongly agreed, 22% agreed, 11% somewhat agreed. By the way, all these responses were to a questionnaire, and they're de-identified, so the patients know that I don't know what they said about the surgery. If I had a family member or a close friend, would I recommend the same? And the response is fairly similar, except 5% somewhat disagreed. My quality of life was improved. 50% strongly agreed, 22% agree, and 28% somewhat agree. And I think this reflects the presence of other EDS issues. They need more treatment and other problems. Having this surgery improved my symptoms. Strongly agree, 1/3 agree, 25% somewhat agree, 1/3 somewhat disagree. This is 2 patients out of the 18 that we had collected. I'm going to have to find out who they were, and they will pay. No.
Just out of curiosity, if there is some reduction of motility of the head after the fusion, then they could interpret that as their limitations were increased because they're thinking of range of motion, perhaps. And so you have to. I think it is actually important to find out what they were thinking when they answered the question.
That would be a good question to ask. Just from my knowledge, none of the patients have really complained of loss of head mobility. They all drive, and but there are just so many other issues. But I will look into that. That'd be a good thing to nail down. All right. So the following review of symptoms. I'm going to run through about 15 symptoms now and how they responded to the surgery. And clearly, in some cases, the surgery targeted those symptoms pretty well. In others, it did not. And we need to be looking for other EDS-like problems. So this is 18 patients that we looked at. And average headache, 89% reported a decrease in average headaches. And here's the frequency of headache before surgery in red and after. Now, notice they still have headaches. The headaches have not gone away completely. They're just much more livable. Sorry, that last one was headache pain. And the headache frequency has markedly diminished. Neck pain, 83% had neck pain prior to surgery. 2/3 reported less neck pain after surgery. 1/4 reported it was the same. And so we see the frequency of neck pain decreasing. Sorry. All of the patients reported dizziness before surgery. 2/3 reported feeling less dizzy after surgery. And the frequency of that dizziness, the frequency of that dizziness has decreased. But I just want to emphasize that many of these symptoms are still there, they're just markedly decreased. Vertigo, 56% reported vertigo prior to surgery, 90% less vertigo after surgery. Memory, 83% of patients reported memory issues prior to surgery, and 2/3 of those less memory problems after. So here's the frequency of memory issues, much less common, less often. Some patients feel absolutely wonderful one day, and then a week later they may have a day or two of brain fog. Hearing problems, 60% had hearing before surgery, 54% reported less afterwards, and less frequency of hearing problems. 61% reported speech problems before surgery. Of those, 63% reported less speech problems after surgery. And the frequency of speech problems was less often. Choking and swallowing, 2/3 had choking and swallowing issues, of which 58% reported less problems after surgery. Sleep apnea. Surprisingly, in this group, sleep apnea was not a big problem. I didn't get sleep studies on most of these patients. I should have. So a lot of them probably weren't sure whether or not they had sleep apnea, so let's skip over that one. Fainting, 1/3 reported fainting prior to surgery, and after surgery, 50% less fainting. I think that's underreporting when we get the rest of the data. I think we'll find that the amount of syncopal episodes is much more, the decrease is much more than 50%. 83% reported visual problems prior to surgery. Of those, 53% reported less visual problems after surgery. Numbness in the arms, hands, shoulders, 77% had issues prior to surgery, of whom 71% reported less problems after surgery. And you see the frequency of numbness in the arms and hands is significantly decreased. Numbness in the back, 40%, of whom 57% reported less numbness in the back after surgery. And the frequency of back pain was less. Walking, 83% had problems with walking, 60% improved. Balance, 83% had balance issues, 73% reported improvement and less frequency of balance issues. Weakness of the arms and hands, 89% prior to surgery, of whom 2/3 reported improvement. Now, in these symptoms, only 1/3 of patients reported improvements. So the surgery does not address, for the most part, joint pain, muscle pain, fatigue, sleep apnea, night awakenings, dysautonomic phenomena such as hands and feet turning cold, numbness and weakness in the legs and feet, that would be more likely tethered cord syndrome, tremors, urinary issues, irritable bowel syndrome, and GERDs. Having said that, I have many notable cases where a professor of economics had irritable bowel syndrome for 20 years, and then after surgery he woke up and he didn't have it anymore. We're just hearing from a family member today who had very floppy joints, and after surgery her joint pains just resolved immediately. So about 1/3 of these symptoms got better, but many of these symptoms also got worse. So it's clearly got the many issues besides the craniovertebral junction. Okay, now all of the patients had some rib pain. It was fairly mild, about 2.7, but I've modified the rib harvesting procedure, and eventually I hope to do away with rib harvesting when I get acceptable alternatives. Limitations of the study were that it was retrospective, so there's some poor recall on the part of the patients. All of the subjects had multiple comorbidities, and let's remember that EDS patients rank a 3 to 4 on a 0 to 5 scale of preoperative morbidity, potential morbidity. To give you an idea, if you're doing a craniotomy on this morbidity scale, that ranks as a 1.5, and an EDS patient ranks as a 3 to 4. So conclusions, kyphotic clavoaxial angle in conjunction with Chiari malformation or craniocervical instability may result in deformative stress on the brainstem and upper spinal cord, resulting in a broad array of neurological symptoms. And these results may be difficult to discern where there's other instability lower in the spine and other EDS issues. Nevertheless, normalizing that clavoaxial angle and stabilizing the joint did improve, in the majority of cases, headaches, neck pain, dizziness, fainting, vertigo, visual and hearing memory problems, speech, swallowing issues, numbness in the hands, arms, shoulders, numbness in the back, walking and balance, weakness in the arms and hands. Now, I want to look at atlantoaxial subluxation. Everyone who comes in with that list of symptoms doesn't have craniocervical instability. They may have instability limited to the first two vertebrae. And if you look at this, this is the C1 ring, and here's the odontoid. And this patient is turning to the left side, and you see that the C2, it's a bit hard for you to, I suppose, recognize, but it's almost dislocated from C1. So this is a very unstable condition. It's a rotary C1-2 instability. And these patients complain of neck pain and headache, worse when driving, especially on bumpy roads, women drivers, nausea, postural orthostatic tachycardia, dysautonomia, pain with neck turning, pain over the C1-2 spinous processes, decreased pinprick sensation on exam. They can feel the pinprick, but you can stick them pretty hard and it's not a painful stimulus, even on the hands. Hyperreflexia, surprisingly no weakness. They have dystiodocokinesia. They're improved with the neck brace and the CT confirmation, obviously, that I've just showed you. And the technique that I've settled on places screws on one side of the vertebrae through C1 and C2, and then I place a bone graft between C1 and C2 and place these small mini plates to prevent rotational torque. Thought I had another picture of that. And this has been very successful. We can do it through a small incision. Patients are up on their feet on the same day. I've had some patients going home on the next day. No complications to date. Keep them in a neck brace for 3 or 4 weeks. No failures of fusion or hardware. Now, this is another subtle problem, and I suppose this pertains to that paper that we published in 2005. And Ed Benzel showed me some very interesting cases of his that looked quite normal on their neutral MRI, and when he did a flexion MRI, there's stretching of the spinal cord and a complete resolution of symptoms. So we know that all patients with EDS have a proclivity to discopathy in all the cervical levels. And if they develop an instability at one level, this can cause a stretch myelopathy with numbness and tingling of the hands and legs, and otherwise unexplained weakness of the arms and legs, gait problems, urinary urgency and other issues, nausea and headache. That's the typical presentation. So here's a patient, normal looking MRI. That's a perfectly normal MRI. But when you get a dynamic sitting upright MRI in flexion and extension, you see on flexion that there's an angulation between C4 and C5 of more than, that looks like about 15 degrees. And on extension, you'll see the C4 vertebrae slipping posteriorly a few millimeters. And so, going back to this picture from Brieg, here's the normal spinal cord. When you bend your neck forward, you cause a stretching of the spinal cord. But if you have a pathological angulation, that causes a lot more stretch. And let me just, Punjabi said that if you have an angulation between vertebrae that's more than 11.5 degrees, that's pathological. That's going to cause neurological problems. So we perform a reduction and a fusion stabilization, just bone from the bone bank and a plate. And this patient had been suffering extreme pain, 9 out of 10, for a couple of weeks, couldn't walk, no balance, nausea, headaches, the full panoply of symptoms that I reported. And once we recognized that problem and fixed it, within 3 days she was up and as normal as could be. So let me go down now to another form of stretching and deformation of the central nervous system, which is tethered cord syndrome. All of these issues deal with stretching the nervous system. And the filum terminale is simply a thread that goes from the conus, the end of the spinal cord, to the base of the spine. And it's normally 0.5 millimeter in thickness and very floppy, but for some reason in Ehlers-Danlos, more often it is thickened and possibly more collagenous and applies a stretching on the end of the spinal cord. Now, when I was in training in the 80s, my chairman, who was one of the greats, Fano Pro, doubted that tethered cord syndrome existed. And by the 90s, everyone recognized that tethered cord syndrome could be diagnosed on an MRI and it became a routine surgery. And then in the 90s, we began to realize that many patients had tethered cord syndrome, but which was radiologically occult. And this particularly appears to be the case in the EDS population. It's a clinical diagnosis. And in the young, the most common finding is weakness of the legs that's otherwise unexplained. You have to rule out muscular dystrophy. It's associated with low back pain, sensory loss, especially in the sacral dermatomes, a neurogenic bladder, and the urodynamics should show a large post-void residual, a sphincter detrusor dyssynergia. And of course, we want to rule out things like diabetes, multiple sclerosis, Lyme's disease. There should be a history of UTI, of enuresis for bedwetting, a history of being pigeon-toed and toe walking, sleeping with the knees bent. And keep in mind that tethered cord syndrome can cause headaches and paresthesias of the hands. So I said that in EDS, tethered cord is usually radiologically occult, but there are other findings that we often see, like this fatty filum, and sometimes we see absence of the bone over the sacrum, what would be a spina bifida occulta. There may be a syringomyelia in the lower cord and scoliosis. And with a patient in the prone position, we may see the spinal cord lifted more posteriorly instead of sagging anteriorly. So there's some soft radiological findings. And here's the filum intraoperatively. You can see here this is about 3 millimeters in thickness. Here, clumps of other nerves. This is the dura that covers all of the cauda equina, the nerves of the lower lumbar spine. So once we take out a piece of this filum, usually the ends retract briskly. So a little ways back, we conducted a random sampling of 13 patients by a third party, and very quickly we saw improvement in 11 out of the 13 patients neurologically, functional improvement in 10, quality of life 8, pain change in 11. All but one patient said they'd do the surgery again, and they would recommend it to a family friend or member. A friend or a family member. The complications of the surgery are usually rather mild. We had one small hematoma, one IV thrombosis, one urethritis, one pulmonary embolism that was treated before it became an issue. But in the last 2 years, I did have 2 pseudomeningoceles, which is a small hole in the dura causing fluid under the skin. I had to go back and reoperate on them. And since then, I've changed my technique, and we've not had any more. So I think that this is a low morbidity procedure with a very high value of improvement. So tethered cord syndrome is the result of tension of the filum terminale and stretching of the spinal cord. In EDS patients, it's a clinical diagnosis, more often radiologically occult. And in well-selected patients, sectioning the phylum improves pain, function, and neurological deficit in more than 85% of patients. I think I'm getting improvement in more like 95% now. And finally, I think we've gone over this list. These are symptoms where we may expect to see improvement in the majority of patients who undergo reduction, fusion, stabilization for craniovertebral instability. I'd like to acknowledge the significant input from colleagues Claire and Brad Tinkle, Ed Benzel, Mark Alexander, and Miles Kobe, 2 neuroradiologists I work with, Stephen Mott, Robert Gerwin, neurologists, Joshua Murdoch, urologist, Alan Posinki, internal medicine. Joel Berry is an engineer who's helped with other issues. Alex Ficarra, Will Wilson, physical therapist. All of my patients have taught me immeasurably. And the Chiari Syringomyelia Foundation is very interested in this interplay of EDS and Chiari malformation, and have sponsored many learning programs. Thank you for your attention.